Okay, let's try that again. Good morning, everyone. Thank you for joining us for the Healthy Transitions Colorado May 2016 webinar. My name is Kristen Paulson. I'm with the Center for Improving Value in Healthcare, and I'm very happy to be here with you today to talk about advanced care planning tools for transitions. So Healthy Transitions Colorado is run by operating partners, the Colorado Healthcare Association, Telegen, the Colorado Hospital Association, the Colorado Rural Health Center, the Colorado Behavioral Healthcare Council, and Health Teamworks, and it's managed by the Center for Improving Value in Healthcare. Healthy Transitions Colorado is a collaborative effort focused on aligning and accelerating existing efforts to improve transitions of care for all of Colorado. Our guiding principle is that by breaking down the silos of healthcare, we can foster true community care coordination across facilities, specialties, and practices. Healthy Transitions coordinates the tools, resources, and efforts of our many partners across the state. We want to keep Coloradans healthy so they can enjoy more of what our beautiful state has to offer. If you haven't already done so, we'd like to invite you to become one of our community partners and take the pledge to improve patient care transitions. To take that pledge and learn more about HTC, visit our website at www.healthytransitionscolorado.org. So I have a few housekeeping things before we get started. The phone lines have all been muted, and they will remain so throughout the webinar. We're going to be using the chat feature available in the lower left-hand corner of your screen to field questions and allow you to make comments on the discussion. Questions posed to the presenter will be answered during the question and answer session after the presentation. This webinar is being recorded and will be posted to the HTC website so you can access this information again at any time without cost. Now I'd like to introduce our speaker for today. Jennifer Ballantyne is currently co-chair of the Colorado Advanced Directives Consortium and an independent consultant serving healthcare systems, hospice and palliative care providers, policymakers, and analysts. She played a key role in drafting the MOST legislation in 2010 and advocating for its passage. Since then, she and other members of the consortium have offered hundreds of trainings across the state. Jennifer, I will now hand the presentation over to you.
Great. Good morning, everybody. Hope you can hear me. So this is the first in a series of webinars and trainings that we're doing with the support of the Colorado Nursing Home Innovations Board. They were gracious enough to give us a grant to do some additional outreach and additional training around the MOST. Like anything, it's the kind of thing that needs to be reinforced periodically, and we are continuing to make updates and revisions and improvements. As well, there have been some pretty interesting developments on the advanced care planning scheme overall. So what we're going to be talking about today, our objectives are to take a look at implementing new billing options for advanced care planning counseling and conversations, to help you plan for changes in the Proxy decision maker statute, which have been approved by the Colorado legislature and will be going into effect here fairly soon, to give you some guidelines for implementing best practice protocol for the MOST conversation. We've had a discussion about the form over the years, and the concern that always comes up is that people get very focused on the form. It's set up like a checklist. We'll be seeing it a little bit later in the presentation, but it's really not a checklist process, and it's really just intended to guide a deeper conversation. So we'll be looking at a best practice protocol for having that conversation and having that discussion. But first, let's take a look at a very big development in the world of advanced care planning. It is now possible to get paid for this process, which we're delighted about. Over the years, as advanced care planning has become more and more important in the management of serious illness, and particularly the end of life, there's been a lot of research into how it's done or not done and how well it works or doesn't work, and a number of barriers have been cited in that research over the years, partly sort of looking on the part of providers in initiating and completing advanced care planning conversations. And what they cite over and over again is lack of communication skills for broaching the subject, not really knowing when to bring it up, how to bring it up, whether to bring it up. lack of knowledge about the process of advanced care planning, as well as the specific legal provisions of advanced directives. Lack of time is cited over and over again, and also kind of as almost as a throwaway, oh, we don't get paid. And so we've taken down finally one of those 4 barriers, and that's a good thing. But it is now possible through revisions from Medicare to bill for advanced care planning. And this just went into effect this year as part of the final rule for physician payment from the Center for Medicare and Medicaid Services. They have established 2 CPT codes for advanced care planning. One covers the first 30 minutes of a face-to-face explanation and discussion of advanced care planning. This can't be telephonic, it can't be through email, it has to be face-to-face, between a provider and then with a patient and or that patient's surrogate, a legally authorized decision maker. The physician or other qualified health professional must be conducting the conversation with the patient or surrogate. And that conversation may or may not include completion of advanced directives. There isn't any particular goal to this conversation that's directed by CMS or by the billing. It could result in a completed advanced directive. It doesn't have to. And then there's a second code for each additional 30 minutes that is necessary for that conversation. Now, as anyone who has looked at this will tell you, the amount of money that's attached to these CPT codes is not enough to change anybody's life, but it is something, and it does at least reasonably compensate for the amount of time. And as I mentioned, it lowers a barrier. The biller of these codes must be the managing physician of the process. However, the person conducting the conversation can be this other qualified health professional. It's a little bit unclear in the rules as to what other qualified health professionals would count, but whoever they are, they must be under the direct supervision of the physician. So it's a little unclear. They're still kind of working out some of the nuances of this, but it is possible for someone else, for instance, in a family practice or in a clinic or even in a facility, to have that conversation with the patient as long as they are under the direct supervision of the physician and as long as the physician is materially involved in the sort of the larger conversation and the management of the patient's care and the outcome of the conversation. And of course, for these CMS codes, the patient must be a Medicare beneficiary. So that's brand new this year. We're starting to get some sense from CMS. Not too many people are using this just yet, but we're hopeful that it will catch on. In Colorado, since 2013, it has been possible to bill Medicaid for most counseling specifically, medical orders for scope of treatment counseling. This billing does not extend to other kinds of advanced care planning conversations, unfortunately. It is very, very specific to the most, but there is a billing code here for a 30-minute session in addition to some appropriate other evaluation and management service. This can only be billed once a year. The biller must be a physician, and I mean once a year per patient or per beneficiary. The biller must be a physician, nurse practitioner, or PA, or licensed mental health provider. And the patient obviously must be a Medicaid beneficiary, but must also have some serious chronic or terminal illness. The other little wrinkle to the Medicaid billing is that you must, as the billing provider, must be able to produce evidence of training in the most process and form if you are ever audited by the state. So keep your records from this training, and if you get asked, you got it. So moving on. The other big update in the advanced care planning world in Colorado is updates to the Proxy decision maker process. And just to remind everybody, just so we're perfectly clear here, there is a distinction in Colorado between the Proxy decision maker and the healthcare agent. These are two different things, although oftentimes in other states and in other contexts, proxy and agent are used completely interchangeably. But in Colorado, there is a distinction. And the distinction is this. a healthcare agent is a medical power of attorney specifically appointed through that process with the appropriate paperwork in place, designating where a patient or resident would designate someone else to be their healthcare agent, their decision maker, if at any point the patient or resident becomes unable to make their own decisions. If that does not happen, if the patient or resident has not specifically and formally appointed a healthcare agent, and that person then becomes incapacitated and decisions need to be made, in Colorado law, which is almost unique across the nation, there is a provision for the physician to gather together so-called interested persons. And an interested person is someone with a relationship to the patient. It could be by marriage, it could be a spouse, children, parents, siblings, cousins, but it could also be a close friend, someone who is not related by blood or marriage or some formal relationship, but is a close friend or confidant of the patient. The goal is to gather together as many of those interested persons as possible and then have them select from among themselves the person who knows the patient best, who then becomes that person's decision maker. And as bulky as this is, and as somehow sort of fraught with a little bit of peril in some cases, it actually works. It works pretty well for most situations. The one situation that it has not worked well in is when we have an incapacitated patient and they don't have any interested persons, or we can't ask the patient, who are your interested persons, how do we contact them, how do we gather them together? And this gives us then the problem of the so-called unrepresented patient, and what do we do with that person? So after a very complicated...
I'm sorry to interrupt. We've had a request for you to speak up a little bit or move closer to the microphone so that you can be heard.
Okay, I've put it right up to my mouth. I hope that helps.
Thank you.
Okay, so after a lot of discussion and looking at a lot of different ways that different states handle this problem of the unrepresented patient, a bill was introduced this year to the Colorado legislature to propose, and now it's been passed, a process for dealing with this unrepresented patient. So here are the changes. If we have an incapacitated patient who does not have any interested persons, it is now possible for the attending physician to designate, along with the consensus and advisement of a healthcare ethics committee, another willing physician to serve as that person's proxy. Once that is established, that person is established as the proxy, the attending may continue to make all routine medical decisions for the incapacitated person, but any decisions requiring informed consent or having to do with end of life, which is what EOL stands for, anything requiring informed consent or having to do with end of life, for instance, withdrawing treatment, withholding treatment, the proxy physician would make those decisions, and again, with the support and advisement of a healthcare ethics committee. So it allows for another person to be brought into the process, and a person who is likely to be ready to hand. And this situation tends to come up most frequently in facilities, either in hospitals, or in nursing facilities. And there is an attending physician, but there is also, usually available another physician who might be willing to serve as that person's proxy. This proxy designation will end at the discharge of the patient from that facility, or if the patient recovers their capacity or another interested person turns up. So this is the process that's been outlined in the new proxy decision maker, in revisions to the proxy decision maker statute. So I just want you to be aware of that, that there is this provision now to handle the unrepresented patient situation. More to come, I'm sure, on that as it unfolds. So let's turn now to the main topic of our presentation today, and that is a protocol for a best practice for the most conversation. And you can use this same protocol, this conversation, in other advanced care planning situations. The goal is really to sort of move beyond the form, move beyond the checklist, and to get to a much more substantive conversation. So just to remind everybody, the MOST stands for Medical Orders for Scope of Treatment. It is part of a national paradigm of advanced care planning and portable medical order sets that is referred to as the POLST paradigm. POLST standing for Physician Orders for Life-Sustaining Treatment. This paradigm is rapidly moving across the country. I think there are now only 3 states in which a POLST paradigm program is not in any stage of development. I think there, if I remember correctly, there are about a dozen states where the POLST or MOST or other variants of it are up and running, established by legislation or regulation, and about 20 some other states where such a program is in development. In fact, Wyoming just recently passed their legislation for a POLST paradigm program. So all of our neighbors now are on board with this paradigm, as well as many other states across the country. The goal here, the MOST is a portable medical order set, and what that means is that it's a standing set of medical orders that are accepted and must be accepted in any healthcare setting across the state, regardless of whether the signing physician has privileges in that facility. So the goal is to have a standing medical order set that travels, quote unquote, with the patient as they move from setting to setting, so that, again, in theory and ideally, we don't have to start over every time someone walks through a different set of doors. It really is intended for people who are seriously ill. This is not for your backpacking, square dancing, very fit mountain climbing seniors. This is really for people who are seriously ill, chronically ill, or perhaps terminally ill. For people who are frequently in contact with healthcare providers and perhaps are at risk of being incapacitated and unable to express their particular choices. The POLST MOST, the MOST is intended to stay current with the patient's current condition and wishes. It's intended to be updated regularly, and it's intended to stay with the patient, as I mentioned, as they move through these different settings. Copies, faxes, and scans of the MOST form are all equally valid. It doesn't have to be the original form. It cannot be required, for instance, in a nursing facility, you can't require every resident to have a MOST. A physician practice can't require every patient to have a MOST. However, if a person has a MOST, the honoring of the choices that are designated on the MOST is required by statute. So how does this fit into the whole sort of larger universe of advanced care planning? Ideally, at the moment that someone turns 18, and this actually more or less happened in my household, but I'm not sure it does anywhere else, at the moment a person turns 18, they should, ideally, complete an advance directive, at least designating a medical power of attorney, someone to make decisions for them if they should become incapacitated, and potentially complete a living will. From my perspective, the medical power of attorney is what is most important for people who are young and healthy. That advance directive, whatever it is, should be updated periodically as life circumstances and health situations change. At the moment that a person becomes diagnosed with a chronic or progressive illness at any age, that's when a MOST form is most appropriate. So is, as I mentioned, is this medical order set that is intended to travel with the patient. And once that is completed, the idea is that everywhere that person goes, those treatment wishes are honored. Now you'll notice that all along the way here, what is required to make all of this work is conversation. It's required to ensure that everyone knows what is informing these choices, what the values are behind it, what the thought process is behind it, because the MOST form, as you'll see in a minute, is a checklist. It just says what the choices are. Likewise, many living wills are just checklists. Do this, don't do that. So it's important to have that conversation and to really expand the conversation beyond just the patient and their particular provider or the patient and their family members. Everyone should be included in that. So let's take a look at how this actually works. In a perfect world, in another thing, this slide would be cleverly animated to show which step is which, but I think I can, if we start here, ooh, isn't that clever? All right, so we start here, and the most should, this is how the most should work. The most is completed ideally by a primary or attending provider, completes the most with the patient and their surrogate, and that in-depth conversation that we're going to be talking about in a minute, and completes the form and hands it to the patient. So Mrs. Jones goes home after this wonderful conversation with her primary care physician and slips over the throw rug and falls and hits her head. And so her husband immediately calls the EMTs, and they turn up, and the husband hands them the most form and says, you know, this is what my wife wants done. And the EMTs take a look at it, and they say, great, thank you very much. And they bundle Mrs. Jones with her most form into the ambulance and then take her to the hospital. And at the hospital, Mrs. Jones and her most are presented to the emergency room, and the emergency room folks can take a look at it and say, now we understand what Mrs. Jones wants or doesn't want, and the orders that are outlined on the most are pulled off and entered into the system as Mrs. Jones' incoming set of orders. Pending change, perhaps pending update, depending on what happens during her hospitalization, but the most sets the stage. These are the incoming set of orders that Mrs. Jones wants. If Mrs. Jones is admitted, and let's say she ends up having to have surgery, as I mentioned, the unfold, other choices be made, but the most sets the stage and establishes that immediate incoming set of orders. The most at that point goes into the plastic bag with the wallet in the teeth and the wedding ring as Mrs. Jones' personal property. After her hospitalization has unfolded and various decisions have been made along the way and various things have happened and various outcomes have unfolded, Mrs. Jones then is ready to be discharged to home. And her physician, ideally, or the discharge planner, then has a conversation with her about how has it been for you, Mrs. Jones? You're about to go home or to the skilled nursing facility, and let's go over your most form and see if any of your wishes or choices have changed. At that point, at discharge from the hospital, ideally the most form would come out of the bag with the wallet and the teeth and the wedding ring, and it would be updated based on Mrs. Jones' experience in the hospital, so that then wherever she goes from there, whether it's back home or to the nursing facility, she now has an incoming, updated, current set of orders coming into the nursing facility or back to home, so that we now know coming into the facility or back to home what Mrs. Jones' wishes and choices might be. That's how it's supposed to work. We have learned through experience over the years that it doesn't work ideally like this, that there are opportunities for failure along the way. But that's why we continue to do this training, and we continue to emphasize the continuity that is necessary for this whole process to work. Now, ideally, it would be great if we didn't have to rely on a green piece of paper for this, if we had an electronic registry, or if people's most forms were reliably in their electronic medical record. We're working on that at a lot of different levels and stages, but right now we're still kind of dealing with the last century option of the paper form. But this gives you an idea of how this should work and how the various links in the chain should be connecting up. So with that in mind as the most process, let's look again more generally at advanced care planning to remind ourselves that it is a process. It's not an event. It's a process of discerning goals, medical and non-medical. It's intended to plan care to meet those goals. So first of all, we have to have an understanding of what the patient's goals are, and then plan the care to meet the goals. It can then result in very specific instructions that are documented on a variety of different documents, and part of advanced care planning is following those specific instructions as they are documented. And the goal here is to steer all parties in the same direction. Just as a reminder, documents are only one part of the process, and documents are the outcome of the conversation. They shouldn't be the sole focus of the process, but the outcome of the larger conversation. So in terms of the timing of the most completion specifically, there's a lot of discussion about this as to when this should happen. In the hospital, our recommendation is that at a bare minimum, anyone who is leaving the hospital going to a skilled nursing facility, if they did not come in with the most, this would be a great opportunity to introduce the most and have this conversation, and so that they then leave with a current set of orders in hand. So in the nursing facility, ideally, they're coming into the facility with a most that has been recently completed or updated. If that's not the case, it can be initiated in the nursing facility as part of the admissions process, but not, I emphasize, immediately, quote unquote, upon admission. This does not have to happen in the first 20 minutes while the resident is still on the gurney and before they've been put into the bed and everyone is exhausted because it's 8 o'clock on a Friday night and the person has been in transfer for 4 hours. I understand that nursing facilities are very keen, and appropriately so, to get information about code status right away. That part of the form can be completed separately and immediately if that is really strictly necessary, and then leave the rest of the conversation for another time, preferably within 48 hours of that person's admission. And I'll just mention, too, for people who are in nursing facilities long term, it should be updated at least quarterly or at any change in the person's condition. In palliative care, the most is a wonderful thing to do at the conclusion of a consult, after you've had that in-depth and rich conversation, to record the choices and the wishes of the person on the most form. In home health care, if someone is being followed consistently at home at the first or second home visit, is a great opportunity to do the most. And likewise in hospice, within 48 hours of admission, sooner if the patient is acute. But the idea here is to get this done as expeditiously as possible, but not necessarily immediately in the next 20 minutes of the person encountering the setting that they're in. So let's turn now to the protocol for the most conversation. And the very first step here is to determine the capacity of the person to participate. This is tricky, and I'm certainly not going to be giving you a lot of lessons in determining capacity. I'm relying on you to have your own processes for that and your own procedures and policies and protocols in your setting to determine the capacity. But it is important that the person have the capacity to make the decisions that are being asked of them on this form. Just a couple of reminders about capacity. It is decision specific. So you need not have somebody who is universally competent in all aspects of their life to participate in a most conversation and to express their wishes. So this is it's important to take the patient where they are and understand what their wishes might be given their capacity at that time. The second step in this is to describe the purpose of advanced care planning and to normalize the process. Hopefully these conversations become much more routine than they have been. I think it's people oftentimes these conversations don't come up until the person is in pretty dire straits or things are sort of heading into perhaps an emergent or an intensive situation, and that raises a lot of alarm bells with people. Like, why are you asking me about CPR? Why are you asking me about these things? if we can pull back from that and normalize the conversation a little bit more, I think it's much more helpful to be able to say, advanced care planning is a way for us to explore your goals and preferences, answer your questions, clarify what choices you might have. We do this with all our patients. We do this with all our residents. It will help us give you the care that you need and want. Just to kind of put it in the context of the larger experience of care and not have it be just this kind of scary thing that is introduced only when things are going south in a big hurry. The third step here is to ask patients, do they already have any previously completed documents? This is especially important to determine, do they have a medical durable power of attorney? Have they appointed someone as their surrogate decision maker? And if they have not, this is a great opportunity to do that in the context of this larger conversation. As we've talked about, it's really important, especially in Colorado, to have someone designated as a medical power of attorney. And if they don't have one and things do go south, then we're stuck with that very difficult proxy process, and we would rather just have a designated medical power of attorney. It's also important, though, to ask them, do you have a living will? Do you have other advanced care planning documents? In part because we want to make sure that their current wishes, the most, and their other advanced directive documents are all consistent. That's the ideal situation. So often we've had situations where someone has been incapacitated, decisions have to be made, and we don't really know what their current wishes are because we haven't asked and don't have anything very recent. And then all of a sudden a living will emerges from a safe deposit box and it was completed 35 years ago. Well, that's better than nothing, maybe, but it would be better if we had things that are updated and consistent with each other. There are rather complicated rules about what document trumps what document. You can find that on the ColoradoAdvancedDirectives.com website. I'm not going to go into it in this presentation, but just be aware there are some nuances. It's not necessarily solely based on which document has been most recently completed. But again, we can avoid a lot of those conflicts and confusions if everything is consistent. So asking about any previously completed documents is really helpful as part of this process. If the medical durable power of attorney agent is present, and again, ideally they should be for this conversation, it's helpful to confirm their understanding of their role. The medical power of attorney is intended to make decisions for the patient or resident when they cannot, and according to their values, the patient's values, the resident's values, not the agent's. So emphasizing that is not inappropriate at this particular point. Asking the agent, what do you understand is your job as a healthcare agent is a great way to open this, and just find out what they understand about that and gently correct any misunderstandings about what their job might be and how they need to be involved in the patient's care. Step 5, this is still just a very general conversation, and it's helpful to explore the patient's understanding of their current medical condition and their prognosis. This can just be introduced very gently. What have your doctors told you about your illness or your diagnosis? What do you understand is going on? This is a very standard opening question in a palliative care consult, and it's astonishing how often patients really don't understand what's happening. They don't have a good understanding of what their condition is or their prognosis is or where they're likely headed with the illness. If you are not the physician having this conversation, really this part of it is really just to understand what the patient understands. If they have questions about it that you can't answer, you can make note of that and refer back to the physician to get those questions answered. But really at this point, you're just trying to understand what they understand about their situation. Always in these conversations about medical conditions, prognosis, diagnosis, treatment options, try to be really simple, easy to understand language. It's amazing how much jargon we use without even really realizing it. Even the phrase that it seems as simple as goals of care may not be completely obvious, to the resident or the patient as to what you're actually asking them. So just be aware of your language and try to keep it as simple and straightforward as possible. The next step here is to just explore the person's understanding of potential complications, where they might be headed, where their disease trajectory might be taking them, what kinds of things could occur, and that, of course, is going to depend on what illness it is that they have. But again, kind of exploring their understanding of what those complications might be. And you may find that this conversation has not really been broached with the patient. No one has really helped them to look ahead down the road a little bit, to think about what might be coming next. And this is a very useful part of this conversation. Again, just taking it as far as you feel comfortable and noting any questions for the physician or someone else that might be more knowledgeable if you are not. Step 7 is kind of optional, but it may be helpful. The people are having kind of a hard time articulating what they understand about things and what their wishes might be. It's helpful sometimes just to explore or refer back to their experiences of their own experiences with their illness, perhaps over the past year or whatever period of time it's been unfolding, or other family members who have had experiences coping with serious illness. And some of the questions that you can ask to prompt that, or has anyone in your family had this same condition, or what was your last hospitalization like for you, or how have things been unfolding for you over the past 6 or 8 months, whatever it might be. The goal here is to get them to articulate what their feelings about things are in terms of what treatments they have had, what their experience with that was. What you may find people saying in this context is things like, oh, I was on that ventilator and oh my God, I never want to be on a ventilator again. Or they might say, yeah, it was rough, but they saved my life and I'm really glad they did it. Just to get some qualitative statements on their experience of illness and their experience of treatment. And then you can explore, after that, the last several questions have been kind of rough and perhaps negative and focused on their illness. Step 8 gives you an opportunity to sort of pull back the lens and explore with them what gives their life meaning. What kinds of things do they enjoy? What makes for a really good day for them? And then also exploring fears and worries about illness or care and their particular immediate needs and support. Now, usually when I get to this point in the conversation, and if I'm in a room where I can look at people, what I see is a lot of concern about, oh my God, this is already an hour-long conversation, and I have, even if I wanted to, I couldn't take that much time with the patient. It doesn't have to be an hour. The goal here is to give the patient an opportunity to articulate their understanding of their situation, their evaluation of what their experience of illness and treatment has been like, and what they're most concerned about. It doesn't have to be 45 minutes. It doesn't have to be the person's entire life story. Just touching on some of these things will give you a better sense of who they are and what they want. So just to alleviate any fears about how long this might take. And the more you do it, the more comfortable you get with it and how you can kind of control the time with it. But you'll notice that we're now on step 9 of the process before we ever even get to the form. So all this while, if you are talking to the person, you're sitting in a chair and the form is in your lap. You haven't even necessarily showed it to them yet. You have not taken any notes on it yet, although you might be taking notes on another piece of paper. But the goal here is to just really get to know the patient before you even talk about the form. So step 9 is introduce the form. And for those of you who are not familiar with the form, this is a quick glance at it. You probably can't read this very, very well, and we're not going to be going through it in any great detail, but I encourage you to go to our website, coloradoadvanceddirectives.com, and download it. There's a link right on the home page. You can download the form and look it all over. But you'll notice that it addresses only a very small subset of all of the many, many, many decisions and choices that a patient might have to make in the context of serious illness. It really touches on the most sort of major and general choices. Box A addresses CPR. Do you want CPR? Yes or no? Yes is the default, but this does allow people to actually say, yes, I do want CPR. No is the other choice. And in explaining the treatment choices, and we'll look at this in a minute, but explaining the treatment choices, I encourage you to really be pretty candid about the likelihood of success of CPR. And we have some other resources and tools on the Colorado Advanced Directives website that will help you with that conversation in very plain language about how CPR might unfold for this person in this situation. Box B covers more general scope of treatment and the general guidance for interventions and the scope of interventions that the person might want. When we revised this form a year and some ago, we adopted language from the California form, which had just been recently updated at that point. And the thing I really like about it is that it really puts the emphasis on the goal. So under full treatment, it says the primary goal is to prolong life by all medically effective means. So that gives you an idea of, okay, if I pick full treatment, that is my goal. On the other hand, for comfort-focused treatment, the primary goal is to maximize comfort. That doesn't mean that other treatments are impossible under that, but the primary goal of the treatment is comfort. So the conversation then for Box B is really about what is your goal? What is your goal for your treatment and for our care of you? Box C addresses medically administered nutrition, and we greatly simplified the choices here from the previous version of the form. It just talks about tube feeding, long-term, short-term, not at all. And specifics about the short-term can be added. And then Box D just says who we discussed it with. The rest of the form is signatures, and all of the necessary signatures are now on the first page of the form. So that's about all I'm going to do in this session in talking about the form itself. You can download it from our website and look at it in more detail at your leisure. But as you move through the form, the general pattern in discussing each of these sections is the following. Explore the person's understanding of the option that is being put in front of them. Explore their understanding of the risks, burdens, and benefits, adding information and clarifying misunderstandings as necessary. Exploring their goals and expectations about that particular treatment or scope of treatment, their fears and concerns, and then making sure that you align the choices that the person is articulating with their goals. So once the form is completed, then you can review and update as needed. As I mentioned, at any change in condition or new diagnosis that the person experiences, assuming you're having an ongoing relationship with them. In primary care, it's a great opportunity to do this at every wellness visit, just to get out the form and go over it. In the nursing facilities, absolutely at every quarterly care conference, if not in between. If things change in between, it's important to update it. And then in the hospital, as we talked about, at discharge is a great opportunity to review it, and obviously at admission and readmission. The original form belongs to the patient and should be sent with them if they are leaving your facility for whatever reason. And I know that nursing facilities in particular have a little bit of squeamishness about this, but the original really should go with the patient, and then you can keep a copy in the chart or in your records. But just as a reminder, faxes, copies, and scans are just as valid as the original. And as we talked about earlier in the presentation, Medicaid and Medicare billing are now available. Just a couple of quick tips and tricks here. This is actually articulated specifically on the form, but just as a reminder, if somebody picks yes CPR, full treatment is really the only possible option in the next box. We can't do yes CPR and comfort measures only. It's just it's medically impossible to have that particular combination. On the other hand, you can have no CPR and full treatment. So just be aware, though, that if the person picks yes CPR, full treatment is really the only option in box B. A number of people who have gotten really comfortable with the MOST form and do these conversations a lot find that they start with Section B first and really talk about it in terms of the person's goals. And then, based on what they choose in Section B, then circle back to the CPR question, and it may be that whatever the person has selected for Section B will emerge, will point to whatever choice they might want to make in CPR. So you're not leading off with the kind of scariest scenario possible. As we keep talking about, the important thing is to explore the patient's goals and then align the choices on the form. Section C, that's the section that has to do with artificial nutrition. Just as a reminder, there is a parallel set of choices that are laid out in this Colorado statutory living will. So it's important to double check any wording regarding artificial nutrition that may be in that person's living will already, just to make sure that you either update the living will to align with the MOST or make choices on the MOST that align with the living will. And as a reminder that proxy decision makers, as distinct from medical agents, cannot refuse artificial nutrition independently for an incapacitated patient. There are some caveats around that, which if you have specific questions about, we can go over. Signatures are important. Be sure that the patient or the person or their agent signs it, the physician, APN, or PA. If the person signing the form is not the person who had the conversation, it's important for them to review the choices and make sure that they're okay with it all and that it seems to align with what they understand is the person's condition. Telephone orders are okay, faxes are okay, and then of course you would file and follow up per your facility policy. As I mentioned, the revised form is available from the Colorado Advanced Directives Consortium website, as well as abundant other tools and resources. I encourage you to go on there and poke around. That being said, the old forms continue to be valid. We just encourage you to update them and start using the new form sooner rather than later. We are going to be having some more intensive hands-on interactive trainings around this conversation protocol coming up June 22nd in Grand Junction. The registration for that is open. These trainings are free, so the registration for that is open now on our website. And then we'll be having another training in Colorado Springs in August, and then probably sometime in the fall in the Denver area. So that concludes my presentation. I'm going to leave this resources slide up here for you to jot anything down that might be necessary, and then we can open it up to questions at this point.
Great. Thanks, Jennifer. We've got one question right now on the board. If you all would, use this time to really ask any questions you have of Jennifer in the chat box, and we'll get those answered. So right now we've got a question from Christine LaRocca. Can you please specifically describe the differences between the POLST and the MOST?
So POLST is the generic term that is attached to this whole general paradigm or scheme for establishing and documenting and communicating portable medical orders. It's called POLST because it started in Oregon, and that was the acronym that they attached to it. As I mentioned, it stands for Physician Orders for Life-Sustaining Treatment. As other states have adopted it, different variations of it have been utilized. We use MOST in Colorado. There are some states that call it POST for provider orders for scope of treatment or physician orders for scope of treatment. New York is MOLST, M-O-L-S-T, for medical orders for life-sustaining treatment. And really, the differences are nuanced. They're either just differences that have been adopted to accommodate local culture, local preferences, as well as local laws. The forms may be slightly different from each other based on what that state's laws are around advanced care planning and medical order sets. There is a national pulse advisory task force, however, which sets the standard and determines whether state programs and their forms are meeting the standard. So there is some standardization around it, but like anything else in the United States, there's the standard national model and then all of the state variations. So I hope that helps explain that.
Great, thanks. We've got another question here from Elizabeth Paradise. Please clarify the artificial nutrition provision. Can an MDPOA or proxy demand artificial feeding if the patient had documented they did not desire it, or vice versa?
Yes, that's an important question, and I always answer it in two parts. There's the technical legal answer to that, and then there's the real world answer to that. Technically, legally, if a patient has documented in any form, expressed in any form, in any way, on an advance directive, in a documented conversation, any healthcare decision, specifically in this case, do not give me tube feeding, then their wish should absolutely stand, and no, a medical power of attorney or, and particularly not a proxy, can override that, but there is, in the current living will, there is a place for determining, making choices about artificial nutrition and hydration on the living will, which should not be overturned, but it's possible in the living will to say, but my medical power of attorney can overturn these choices if they so desire. So if that box is checked on the living will, the medical power of attorney can override a choice that's documented in a living will. Other than that, again, technically, legally, they should not ever be able to override what the patient has stated and documented. In the real world, however, it happens. I don't like it. I never approve of it, but I think what sometimes happens is that family members or agents get very insistent, and providers are concerned about the fallout of what might emerge from that conflict. I don't know how else to answer the question. It happens, but it shouldn't.
Great, thanks, Jennifer. We've got 3 more questions so far. Can the physician proxy sign a patient into a skilled nursing facility? This is from Susan McFadden.
That's a very good question, and I'm not 100% sure of the answer, and here's why. In part because the physician proxy provision is very new, and it's unclear exactly how this is all going to work out. The other part of this, however, is that proxy decision makers are intended to be temporary for a particular set of decisions that need to be made right now. It's not really intended to be an ongoing, durable role for the person. And so proxies really ought not to be in a position of signing a patient into a skilled nursing facility, because that implies kind of an ongoing role beyond an immediate set of medical decisions that need to be made right now. So my inclination is to say, not really, but would it be possible? Possibly. The proxy is really intended to be a temporary solution to an immediate problem. If then that person does not regain capacity and they continue to need these kinds of decisions made for them, then the next logical step is for someone to go seek a guardianship, and then that would take care of those kind of more long-term kinds of decisions.
Great, thanks. Annette DeGroot asks, does a most form filled out in Colorado follow someone into Wyoming or other states?
Very good question. What you'd have to do is check the Wyoming statute, and one of the standards, however, one of the standards that is in place from the National Pulse Paradigm Task Force is that there be reciprocity. So the standard is that, and this is also the standard for any advance directives, that states recognize and honor advance directives that are completed in other states. So if your grandma is out here visiting from New York and she ends up in a Colorado emergency room, but she has a living will, et cetera, that should be honored. Whatever she has in place for New York should be honored in Colorado and vice versa. I will tell you that the most statute in Colorado does recognize other states' most and pulsed and other paradigm forms in Colorado. Whether Wyoming recognizes Colorado's, you'd have to just double check that with the Wyoming statute. But there is this national standard that there be reciprocity, so my guess would be yes.
Great. We've got one more question from Rick Jewell. Has there been any noticeable difficulty or obstacles in obtaining this particular documentation with those individuals living with a severe mental illness?
So I'm not sure what's meant by obtaining. Are you asking about having the conversation with someone with severe mental illness and documenting their choices, or are you talking about retrieving the documentation, or it would be helpful to have, okay, so conversation.
Specifically regarding having that conversation and then the follow-through.
Well, yeah, of course, and a lot depends on just exactly what the severe mental illness is and to what extent it is impairing that person's capacity to make these kinds of decisions. The mere presence of mental illness per se does not render a person incapable of making medical decisions. It would depend a lot on what is the mental illness, how severe is it, how much has it detached the person from reality. The requirements for capacity, first of all, understand the information that is being given them about whatever the decision is. So they need to understand the language and they need to understand the words. So it has to be given to them in a language that they can understand, as well as really comprehend the meaning of those words. They have to be able to evaluate the information in terms of risks and benefits and evaluate it in terms of their own goals and preferences. They need to be able to make a decision, and they need to be able to express that decision. So there are 4 features there. Severe mental illness could impair any one of those 4 features. So really it's going to be a case-by-case basis of determining how capable is this individual with whatever mental illness they have of meeting those requirements for capacity and making the medical decision that's at hand. So I don't know if that helped, but I hope so.
We got one more quick question before we need to sign off. Does a more recent orally appointed medical durable power of attorney trump an older written medical durable power of attorney?
Yes.
Well,
how's that?
Okay.
How's that for a simple answer? Yes,
okay.
But it does need to be documented,
Right.
and it should be followed up. It should be followed up with a written document following the verbal appointment.
Perfect. Well, thank you so much, Jennifer. I really appreciate it. And thank you, everyone online, for joining us. I hope this has been an informative and productive hour for you. This webinar has been recorded, and it will be available on the HTC website along with the slides in the next few days. And you can feel free to access that as many times as you want to. It's up there as a free resource. Have a great day, everyone.
Thank you.